international research in the field, is a strong and compassionate clinician. I noticed the title of his talk today is about mapping. We had an incident yesterday with mapping on the way to the restaurant. Let's just say I'm glad he's in the business he's in.
Thank you for that very kind introduction. I'm actually delighted to be here. I mean, what this field has needed for so long is really passionate families that are involved. And I think as you're going to hear over the course of this meeting, how well this has worked for other disorders such as autism, and really how I think it can really change the playing field in eating disorders. So I'm really delighted to be a part of this. And so let me go ahead and get started. I'm going to talk a little bit about science and evaluation and treatment, but I think one of the things that we need to acknowledge that our evidence base is really pretty limited. And the question is how that kind of interacts and clashes with trying to develop standards of care, what's really being done out there in the community. And while data is critical to making informed decisions, we don't have very much data. And as Cindy has pointed out, this is really complicated. And there's many different points of view about what causes eating disorders and how do you arrive at some kind of consensus. And I'm going to talk a little about our program basically as kind of a model for how this can be done. And I think this is very worthwhile. It's going to be an evolution, but it really is necessary to raise the level of care. So in the spirit of all these different analogies, you can look at eating disorders as being kind of a jungle out there, and how do you kind of make your way through this jungle and make sense of it? And so one of the things to do is maybe kind of look at what's been done in other disorders and in medicine and the pathways that they've followed. And one of them we can take a look at is coronary heart disease. Now, I think you can kind of make the case that behavior is maybe 50 or 100 years behind where we are in medicine, other fields of medicine. Unfortunately, we're really still very much dealing with people's symptoms. We don't really understand the underlying mechanisms. And of course, in heart disease, if you have a blockage of your coronary arteries, we understand a lot now about the biology of that. You can actually measure, you can do a lot of different things to measure those, the blood flow in those coronary arteries. There are a lot of different treatments that have been proposed, but more importantly, there have been replicated studies that try and get at what's the most effective kind of treatment, whether it's medication or stents or bypass. There's in service of this, there's been a comparison of long-term outcome. It's not just if somebody is alive, when you treat them, but how are they doing 2 years, 5 years, 10 years down the road? That's really what's important. And of course, there's some relationship to insurance coverage. It's not that there's a perfect answer here. It's always evolving. But there's a lot of understanding of this, and it results in guidelines and training of staff. And now, if you go in the hospital and you have coronary artery disease, you have expectations that you're going to get a certain level of treatment. And it's malpractice if you don't get that. If your staff isn't trained to recognize symptoms and do interventions. This is a serious life or death, illness. You want to have competent staff doing that. And so, the jungle has been cleared out, and you have a certain structure to it, like housing development. Joe's just trying to come up with an analogy here. And kind of where we are with eating disorders. Really kind of have a little bit of a clearing of the jungle here. Maybe a couple of shacks, but we've gotten very far in terms of our understanding. There's limited understanding, and even more importantly, agreement on the cause, as you've heard today. Yes, we have some good behavioral assessments, but we don't have the objective measure of underlying brain mechanisms. There are relatively few treatment studies. They reduce symptoms, they improve outcome, but they certainly don't cure the illness. They don't reverse the underlying temperament. There's very little in the way of long-term outcome data, and there's very limited guidelines and training. So we have a long way to go, but I think that this is evolution. And that's really what I'm interested in. I'm trying to take a no-blame approach. It's not that, I think that current treatment is, I think current treatment often does the best they can, particularly the therapists in there that are really providing the treatment, given their training, given their knowledge of the field, they are doing the best they can, but we also have to see what we can do about raising the bar here. And actually, as I looked at this analogy, it's actually, we have kind of cleared out the jungle, but sometimes we build these very nice, facilities that actually, it's not a shack. You actually, have these very nice facilities, almost spotlight kind of treatment centers in this little clearing in the jungle here. So how do you know what's effective? As Cindy has pointed out very nicely, there's these vague claims, a lot of personal opinion. It's kind of, trust me, this works, and of course we offer this therapy or that therapy. And sometimes there's outcome data, which is often done at discharge, when of course people are somewhat better, and that's presented as, look, what a great job we've done. We really know how to treat this disorder. But it's not necessarily published in a reputable journal. So what's the scientific method? How does that work? Let me give you a little bit of window into how we do this, and because I think if you kind of understand something about that, you kind of understand how you evaluate these kind of things. So when you're what you do as a researcher is you're always kind of saying to yourself, what do we know about this problem, and what don't we know? What's the next step? And it's always kind of an incremental, highly focused kind of step. It's not like you kind of answer everything at once. It's usually very narrow. How does this compare to that? And how are you going to get there? And you want to design some kind of rigorous study. You want to avoid bias. So you want to compare, for example, the treatment, you might want to compare two matched groups, treatment as usual versus a new treatment, have enough subjects so we can actually say something meaningful about the differences. And you want to have some reliable and meaningful measure of response. I mean, you can actually measure a lot of things where you can show change, but they may not actually make that much difference. For example, in bulimia with medications, one of the things that has been presented is that, you see a significant response to medication, but very few people actually stop binging and purging. Most of them have a decrement, and so they may go from binging and purging, 10 times a week to 5 times a week. Is that an improvement? Yes. Is that a cure? No. But so it's very important to understand what you're measuring here. And you come up with some kind of statistics. And statistics, are basically a probability estimating how true this finding is. So if you read a statistic like p.05, that says to you that there's about 1 in 20 chance that this actually occurs by chance. So if it's p.01, it's about 1 in 100. If it's p.001, it's about 1 in 1,000. So, it's actually very easy. You can do studies where you can measure a lot of different things, and by chance, something's going to come up significant, and you can go ahead and you can publish that and go like, well, we have this great finding, but it may not necessarily be your hypothesis that you came up with, or it may not be even true. And you want to publish this in a scientific journal. Now, what we do when a paper sent to a scientific journal is the journal then turns around and it sends it to a group of experts. And we very carefully review this paper that's done anonymously, and you send back a review. You don't really care about whether somebody's going to be offended because they don't know who's really doing the review. And you can be really brutally honest about it, and you can say, this is the strengths and this is the weaknesses. And actually, a lot of times papers get rejected just because they're not strong enough. And so it surprised me how consistent reviews tend to be. I would say 70-80% of the time, most of the reviewers kind of have the same points. They have the same kind of an idea. And then how do you decide what journal, the journal is really kind of reliable? One of the things you can do is you can Google the impact factor. And the impact factor gives some gross indication of just kind of how reputable, how much that journal is read and decided by other people. So, for example, the journal impact factor is the International Journal, I think it's about 2.5, something around there. And, American Journal of Psychiatry is about 10, New England Journal of Science is up 20 or 30. And that just says something about the real, about how other scientists, view the value of these papers and they or how kind of, how many people are in the field and they're reading that, and, so so there's various reasons for these impact factors, but two for the international journals really, very, very good. But you'll see journals that have a lower impact factor, and as Cynthia said, it's very easy to get something published somewhere. So you have to kind of be an educated kind of consumer. But the most important thing is replication, and that whatever you publish, it's hard to believe it until you see other people publish in that area and they come up with the same kinds of findings. So that's really, really key. You can't believe just anything, any one finding that you see. So, I was going to talk a little bit, I don't want to take a lot of time, but there have been some recent controlled trials of anorexia. Let me just kind of review this last one here. This was by Gower's study done in England of 167 adolescents with anorexia. And what they did is they looked at three groups of anorexics, those that were treated by an inpatient eating disorder program, those specialized program, those in a specialized outpatient eating disorder program, and those that were just treated by a generalized adolescent service. And they followed them over 2 years. Now this was pre-Maudsley, so that there wasn't a Maudsley treatment because it was designed and done before actually that was very common. But they found no difference in outcomes between the groups, and actually only about a third recovered after 2 years in the sample as a whole. And that says something about the discrepancy in the field between our measures of what we know is true about treatment of people with anorexia, particularly in this earlier stage of treatment, and actually some of the claims that you see from the centers that are claiming that, everybody does well. 95% of people are cured, by our treatment, and that just is, really kind of a big discrepancy. So, and we know that these are very difficult disorders to treat. And I'm not going to talk about, Maudsley family-based therapy, but just to save time. But how do you evaluate a treatment facility or therapist? It's easy to claim expertise and good outcomes, but there really aren't any standards or enforcement or performance. So this is a very difficult area to go in. I kind of put this to the top with a bit of trepidation, but I'm going to go ahead and discuss it because I think as a field it's important to start to raise these kind of issues and also kind of acknowledge how difficult this is to do. So what do we know? Well, as has been discussed already this morning, that genetics and biology and temperament are really very important contributing factors to these disorders, that we're recognizing that it's very common that kids have certain kinds of traits, perfectionism, a drive for achievement, anxiety, obsessive kind of symptoms, pre-morbidly, that is before they develop an eating disorder. It's not like everybody has all these symptoms. It's almost kind of like a menu. Some have one, some have many, some have very intense symptoms, some have mild, but it's not uncommon to see that you see some symptoms. And actually, Lisa Lowenfeld, who's in the audience, did a very nice review paper a couple of years ago that really did a very nice job of describing this kind of temperament. I really recommend that you take a look at that paper and read it. And somehow these traits really kind of reflect some kind of very powerful brain processes that we really don't understand very well, that are responsible for these traits. And these are traits that persist even after people recover in various degrees. As I always often try and make the point that, there's a good side and a bad side to these traits. And these traits, I think, are highly associated with people doing well in life after they recover from the eating disorder, and so that it's very important to kind of recognize that there's a good side and a bad side to this too, and I'll talk a little bit more about how we're kind of trying to develop that in treatment. Another thing that we know is that there's a natural course to this illness. Just as there's an onset in teenage years, there's often an offset in late teens, early 20s, mid-20s. That probably may happen in a lot of people naturalistically. In our studies of recovering anorexics, we actually see a lot of people who have never been in treatment that get better in their early to mid-20s. And that really raises the question about, how much are treatment centers doing and how much of this is kind of the fact that some group of people are really going to get better anyway, and we don't really have the data to really kind of understand the course of the illness, the naturalistic course of the illness. So and that's very important in terms of trying to understand effective kinds of treatment. And it's been noted today, we have some evidence-based treatments, cognitive behavioral treatments, behavioral treatment, personal treatments, medication, where there is various degrees of evidence. But again, these improve symptoms and maybe outcome, but they're not cure or reversal of temperament. And so we really have a long way to go. And we have certain populations where there are particular challenges. Adults with anorexia nervosa, multiple bulimics who have very impulsive kinds of disorders, where we probably don't really have very effective evidence-based treatments at all for these people. But really the question now becomes, how can we translate science into real-life treatments? And the question is, do programs really adopt this new knowledge? Just because we're generating it as researchers and we do all these studies, does it make a difference? Are those programs out there really doing this? Are the therapists thoroughly trained? Are they certified in some ways? And even if this occurs, do they or would they use evidence-based treatment once the door is closed? What do they really do in their office? And do programs provide really prove that their approach results in better and sustained outcomes? And what do you do about these programs where their treatments aren't based on any valid evidence or theories? How do you kind of approach that? And that's really kind of a problem I feel. There's no way to really, there isn't any kind of certification. There isn't any way to enforce this. I suppose one of the things that we can do is we can try and educate consumers. And you can try and educate families as to the ingredients that are most important for effective kinds of treatment, as best we understand those. And realize that, unfortunately, this is going to be sort of a long-term evolution. It's not going to happen immediately, but we need to get started on doing this. So, just in terms of trying to understand, looking beyond the buzzwords that Cindy showed, who does the direct, raise some kind of questions that, ways, that you can try and get consumers to start to raise in some kind of way to ask about treatment centers. Who does the direct care of patients? Who's actually in the room with the patients, whether it's individual therapy or in groups? Is it somebody that's got a bachelor's level degree that's just out of college, that doesn't have very much training? Is it somebody, with some kind of advanced degree? How much time are they spending? What's their expertise? What's the substance of the training that they're providing? I mean, are they spending a lot of time in, some kind of relaxation kind of therapy, yoga and equine therapy? Is there some kind of skills basis to this? Where does the staff come from? Are they full-time? Are they part-time staffing? This actually turns out to be a very important kind of issue because at least in my own personal opinion, it's very important for the staff to communicate, that they need to talk about the patients, and it's much harder to do that with a part-time staff that may be in and out. And you need to have a certain amount of staff consistency. Are the staff basically identified on the website? Who's actually doing that? It's interesting to me. I've gone on the website of a number of treatment programs, and they claim all these terrific treatments, and then you kind of wonder, well, who's actually doing that? And there isn't any description of actually who the people are. What's their credentials? What's their experience? If you've got people doing this, tell the world. And who's responsible for the programs? Who actually owns the programs? What is their eating disorder expertise? Can they be contacted? I mean, the people that are in charge of this, if you've got a problem, who can you go to? My name's on the website, my email's on the website, my phone number's on the website. If you got a problem with my program, call me. I want to know about it. Evaluating therapy and therapists. As you know now, there's relatively few evidence-based treatments. In reality, it's very important to have, we end up relying on our therapist. You want to have stable, sane therapists. They're competent, they have experience, they're warm, empathetic, they're caring. These are actually very important ingredients. I wouldn't, and it's something that I actually put at the top of my list when I'm hiring people. What is their training and degree? The consumer may not realize that there's a wide variety of people in this field, and you have a lot of good therapists that have these various degrees of training, but they may have a very different background. And people that may go through an accredited APA, American Psychological program, that may get 6 or 8 years of training, or go through a child psychiatry fellowship, may have a very different approach and background than somebody who goes through a professional school. It doesn't mean that they may not be good therapists, it just means they may be exposed to a very different perspective on understanding and treating eating disorders. Well, how much time do these people spend in direct patient care? Well, I don't know if staff-patient ratio is the best way to do this, but you want to have an idea of just how intense your staffing is and whether you have advanced and experienced staff that are providing this treatment. And most importantly, how's the staff trained and supervised? Who's in charge? How is this done? Is there some kind of program that's there to actually bring people up to speed, make sure they're doing competent kind of treatment? Do they actually recognize kind of basic, phenomena of this disorder, like when people are anxious and depressed? It's surprising to me, but sometimes people in the field actually don't even recognize basic things like anxiety. Other treatment and gradients. Are there full-time psychiatrists, full-time medical coverage? What's done about dietitians and nutritional approach? How is rate of weight gain assessed? This is a very difficult kind of thing, kind of walking this balance in anorexics between making them anxious or hypermetabolic and yet getting them getting rated in kind of economically feasible kind of way. How are binge purge behaviors handled? Is there expertise for doing individual and family therapy? And does the program publish or present and do any kind of research, which isn't necessarily a measure of quality, but kind of reassures you that they have people that are up to the standards of the field. There isn't time to really go through this in depth, so I just wanted to kind of hit highlights here. And most importantly, I think, and this issue has been raised about this re-entry into the real world. Have patients learned to cope in the real world? Have they learned constructive strategies? How do they manage anxiety and OCD? And one of the things that we're trying to do in our program is we're beginning to learn about these temperaments. We're starting to ask ourselves questions about how can people start to use these temperaments in constructive, effective kinds of ways instead of kind of destructive kinds of ways. Not an easy question to answer. I wouldn't say to you that we have, wonderful strategies, but it's something I think that we're trying to address and trying to come up with better kinds of treatments. What are reasonable progress expectations after discharge in terms of progress? And do people kind of go out there with the illusion that they're going to kind of go from here to here, or do they have a realistic kind of understanding that progress is slow and it's a slow uphill course with a lot of ups and downs along the way? And have these been tested, in real life? Are the significant others involved, and are they prepared for realistic kinds of progress and the kind of persistent anxiety and exceptionality or other kinds of traits that you may see? And outcome studies. Maybe it's nice to present a little data about how people do on discharge compared to admission, but it's not surprising that you show improvements for any number of reasons, whether it's better nutrition or you're not going to try and discharge people until they're doing better. But the question is this really permanent? And the key is really doing long-term follow-ups. You need to show sustained improvement over 1 to 2 years or something like that to really know that this is making a difference. And I think this is important data. This would be good for all of us, because if we could show insurance companies that this treatment really results in sustained care, eventually you would hope, in a just and a reasonable world, which it always isn't, that this is going to result in, better insurance coverage. And that you have to use, meaningful measures and changes that really result in some functional change, not just a measure of a difference. So this may seem a little bit self-serving, but I want to talk just a little bit about our treatment model at UCSD, because we actually have a laboratory there. We develop patient care, but we're trying to develop new treatment approaches and really train therapists in evidence-based treatments, but more on this issue of constructive skill learning based on neurobiology and temperament, and taking the idea that, you know, a partial program is really in a lot of ways, you know, useful here because it allows people to continue to, you know, experience real life kinds of stresses, live with significant others, and learn to manage their life, manage their temperament, and make progress. And it's not, you know, more of a sheltered kind of experience where people are less prepared to kind of reemerge and enter the world. So, you know, and in terms of, you know, seeking, you know, therapists to work on programs, I say, you know, one of the things that's very important is getting people with good social skills, but it's also very important, I think, to have, you know, a very intensive, you know, therapeutic environment. So, for example, we treat roughly about 25 to 30 patients a day, somewhere into that range. And we actually have a very intensive group of therapists. We have 7 PhDs, 4 psychiatrists, 5 social workers or master's levels people, and other kinds of degrees. So you're almost approaching a 1-to-1 patient kind of ratio. And I think that this is very important. Now we're very richly staffed because we do a lot of training and a lot of supervision, but still this is really kind of critically important. And I think it's good to start to ask questions about, you know, the therapeutic, you know, support of treatment programs. And also we devote a lot of time to training. It probably turns out to be about 15% of the time for any, you know, for staff, particularly more junior staff, where we want to make sure that there's a training program in place every week for supervision and didactic lectures, as well as treatment kind of planning. So how could parents help us? You know, we really need data to show what has affected treatment recovery, how behaviors are wired in the brain, how understanding genetics better, but particularly developing better treatments and outcome centers and centers of excellence. And you know, this is what's worked for autism. My understanding is that you've had a lot of parents that have been dissatisfied, that have, you know, gone to the NIH, they've gone to the congressman and said, you know, we're really unhappy with the situation. We want better treatments, and we really want you to do something about it. We want you to provide support for this. And that has actually worked. And there's been a lot of money that has been devoted to autism research. It's brought a lot of new people into the field. It's set up centers of excellence. And that can happen in the eating disorder field. But it's only going to happen if you as family members are invested and passionate about this and get out there and help people if you're unhappy with the current situation. You know, I just want to mention that there are some references for treatment comparisons. There's the NICE guidelines. There's the American Psychiatric and now other adolescent medicine pediatric guidelines that actually do give you some kind of information about treatment guidelines. And I'm not sure that they're actually really used very much by many of the centers, by insurance companies, but they're out there. But in summary, as Cynthia said, you know, if a program tells you what they tell you sounds too good, it probably is. And you know, we're really kind of evolving now in our scientific understanding of evidence-based treatment. Standards of care are needed. You know, this really needs to be a consensus of the field. It's not anything that one person can do. It may be the best short-term kind of solution, but in the long term, what we need to do is this needs to be driven by data, and that's only going to come from research. And you know, ultimately, rigorously, you know, data that's rigorously gathered can be used to really define, you know, what results in good outcomes, and that, you know, should be used to actually define kind of where the benefit should go. So.